Go ahead and get started here.
This meeting is being recorded.
Adam, I think you may have already gotten to do your introduction. I was in and out so many times there, but I'm going to go ahead and start unless you tell me otherwise.
Go for it. Go for it. I gave you a very kind introduction.
Perfect. Thank you. Too kind, I'm sure. Just to start off with here, spinal dysraphisms are what we're going to be talking about today. A spinal dysraphism, as we can see here, kind of from the etymology of it, it's basically a faulty seam in the spine. These midline defects are pretty common. They occur in about 2 out of every 1,000 live births worldwide. Higher in places with poor socioeconomic conditions, kind of given the maternal nutrition factors involved, and lower in places with better socioeconomic conditions, but on average about 2 out of every 1,000. Just under 5% of these are going to be in the cervical spine, just over 5% in the thoracic spine, and the vast majority are going to be lumbosacral. Since we're talking about developmental anomalies, we're going to start off by taking a step back, looking at the embryology involved. We're going to specifically look at these 3 steps occurring from the 2nd through 6th weeks of gestation, forming the notochord, the neural tube, and the conus medullaris, respectively. So first, we'll talk about gastrulation. That's from 2 to 3 weeks gestational age. And this is when the embryonic disc kind of splits from the bilaminar disc into the trilaminar disc. And specifically, it's going to be creating the mesoderm that comprises the notochord. Though the notochord itself doesn't really form much of the spine or the cord, other than it just kind of contributes to the nucleus pulposus. It's what induces the ectoderm to form all of the important things that we actually care about. So a breakdown in this differentiation or formation can lead to disorders like Neurenteric Cysts, Dorsal enteric fistulae, Diastematomyelia, Caudal Agenesis, or Segmental spinal Dysgenesis. All right, so from there, we move on next to primary neurulation in the 3 to 4 week range. In this step, the notochord is going to be signaling the overlying ectoderm. So that's what we're seeing right here to form the neuroectoderm, kind of specifically demarcated in this area here. And that's going to thicken to become the neural plate. So we get the neural plate, and then the neural plate folds to make a neural groove, as we see here. It closes bidirectionally in a zipper-like manner, kind of starting in the middle and working its way both up and down simultaneously. And it closes and forms the neural tube. And as you can see, it kind of separates itself off from the surface ectoderm here. When we look at these steps, it's kind of easy to see how errors in this process would leave an opening in the spinal canal and cause one of the classic images that we think of spina bifida. You can see here, kind of with a very open, splayed out neural plateau here with, kind of a spinal canal that is not quite closed off from the rest of the world. So problems with primary neurulation can lead to things like myeloceles, myelomeningocele, lipomyelomeningocele, always a mouthful there, intradural lipoma, or dorsal dermal sinuses. And the last kind of important step that we need to know about is secondary neurulation happening 5 to 6 weeks of gestational age. And here we have a separate distal caudal cell mass that forms a secondary neural tube right here and fuses with the primary neural tube, as we see. So the cavity of that becomes continuous with the central cavity of the primary neural tube and goes on to it's basically the precursor for the conus medullaris, the terminal ventricle, and the Filum terminale. Problems in this process, understandably, cause some of the distalmost pathologies that we see, including Filar Lipomas, type Filum terminales, and Caudal Agenesis. Disorders in this step can also be linked to sacrococcygeal teratoma formation, but we won't really be covering this in those talk. Another thing to be aware of, given the close relationship between this caudal cell mass and the cloaca, disorders in this step of secondary neurulation can often be associated with anorectal or urogenital anomalies. So finally, the last thing to kind of talk about developmentally is just a reminder on some of the basics as to the movement of the conus. So at 16 weeks gestational age, we expect it to be the tip of the conus expected to be normally at the L4-5 level. By birth, we expect it to be at L2-3. And later on in life, we think of L1-2 as kind of a normal level for the tip of the conus. When we're doing fetal imaging, you can kind of use the lower pole of the kidney as a normal reference point to just kind of make it a little bit easier, since it's often very difficult to really get an accurate count of the spinal levels in those. But below these levels is when we invoke the idea of tethering, which clinically, is going to be accompanied by progressive neurological defects, including paresthesias, pain, neurogenic bladder, kyphoscoliosis, incontinence, or spasticity. All right, so enough embryology. Let's get on to the actual dysraphisms. So here's a little bit of a flow sheet to the right side of the screen, kind of a fairly common way of categorizing dysraphisms. And this is basically going to be the outline for the rest of our talk. So we're going to start off with just this division of open versus closed dysraphisms. And quite simply, open dysraphisms are those in which the neural elements are exposed to the rest of the world. They are out in the open. Closed are where they are covered. So when we're talking about open spinal dysraphisms, we're really talking about two primary entities within this category, Myelomeningocele and Myelocele. So I really love the names of these two because they inherently tell you what the difference is between them. We can see on the left the Myelomeningocele, the much more common one. About 99% of them are going to be Myelomeningoceles. Here we see that there's herniation and exposure of the neural placode and the subarachnoid space. While we contrast that with the kind of diagram we have here of the Myelocele on the right side, and we can see that the neural placode is exposed on a flat plane with the skin, but there's no associated meningocele component. So, it's pretty straightforward from that name, whether there is or is not a meningo component to it. So in radiology, we may not see many of these in postnatal imaging, at least in terms of making the diagnosis, because these are commonly going to be diagnosed clinically or prenatally. So clinically, they can see a midline reddish exposed neural placode, and because this is a neurosurgical emergency, they will take them straight to surgery. Location-wise, these are very, very much favored to be in the lumbosacral region, rare in the cervical and upper thoracic spine, and are often more severe and lead to fetal demise in those locations. Also, as we were talking about earlier, when the neural tube is closing in that bidirectional manner, it starts in the middle, it goes in both directions from there, but it actually completes cranially before it completes caudally. So that kind of is another contributor as to why a lot of these are going to be more often down in the lumbosacral region. With these patients, about 80% of them will have hydrocephalus in addition to these open neural tube defects. And basically about 100% of them will have an associated Chiari-2 deformity malformation. The reason for this is the neural tube closure being defective causes leakage and abnormal drainage of the CSF, which then doesn't allow the fourth ventricle to really develop properly. So you end up with this small posterior fossa and all of your Chiari-2 findings that come along with it. Going back to kind of the prenatal diagnosis of these, it's a very important part of what happens with these patients, and most of them will be diagnosed prenatally by sonography. Some will go on to get fetal MRIs, and that's kind of where we're probably a bit more likely to see them. But in utero repair has really kind of changed the the outcome of these very significantly. So fetal surgery for myelomeningocele in the second trimester can reverse the changes of the Chiari-2 malformation and can preserve neurologic function and reduce need for postnatal VP shunt. So really, in terms of diagnosis of these, it's much more shifted towards a prenatal aspect being kind of the important timeline on that. So here is an example, and the title was hidden. It's going to be hidden on a few of these because this was initially made to kind of have an interactive component, but I think with a lecture of this size, I'll just be going through the images here. So here we have a newborn infant. We've got 3 MRI images here, and we can see very conspicuously this herniation of the CSF. So we've got the meninges component here, and we've got the neural placode extending through this lower lumbar defect here. We can see kind of the corresponding findings here on the T1, and then here on the axial T2, you can really see nicely that meningocele kind of extending out and into the open. And when we go up into the brain on this patient here, as we see on this sagittal T1, we can see the findings of Chiari-2 that we expect to go along with this. So we have the small posterior fossa, low-lying fourth ventricle, beaked tectum, and herniation, and kind of wedge-shaped morphology to our cerebellar tonsils. Here's an example of a myelocele. Unfortunately, didn't have a great one of these personally, so this one's from the literature, but this is also another neonate here, and we can see where the neural placode is really much more flush with the level of the skin, and we don't really have that expansion of the subarachnoid space to call this a myelomeningocele. Again, these are much more rare, going to be about 1% of our open spinal dysraphisms. Like I said, though, fetal evaluation of these is really kind of the much more important part of their treatments. And so here we have a fetal MRI showing us kind of in both the axial plane and the sagittal plane. I've rotated them to orient them relative to the patient. So the maternal organs are at all sorts of wonky angles here, but you can see on the axial image, we have this really nice hernia sac here, this meningocele sac with a very thin wall, and we can see the neural placode extending out into there. And here you can kind of see as well the neural placode extending out into this hernia sac here on the sagittal image. So just to quickly touch on the fetal MRI findings, because of this, the differentiation of an open spinal dysraphism versus a closed spinal dysraphism is an important thing to really help with our fetal surgeons in terms of making that diagnosis, so that they can know whether this is something that needs that sort of an intervention. This is from these criteria are from this paper listed in the bottom right, which is a really nice one that kind of helps parse out some of the differences in patients that have closed versus open spinal dysraphisms. So as we might expect, thinner sac walls are seen in the open spinal dysraphisms, and those should be less than or equal to and greater than or equal to, but basically give you kind of some threshold values there for kind of knowing what a thin versus a thicker sac wall is. So basically under 1.5 millimeters is kind of in favor of it being an open spinal dysraphism. Obviously, seeing continuity with the epidermal and subcu tissues is going to kind of push you more towards saying that it is a closed dysraphism, that there is some skin covering there, whereas if you don't see that continuity, kind of pushes you more towards saying it's an open defect. Again, the open spinal dysraphisms have a very, very high association with these Chiari-2 posterior fossa abnormalities. So those secondary signs can kind of push you towards an open spinal dysraphism. And on the flip side, these OEIS constellation of findings with omphalocele, exstrophy, and perforate anus and spinal defects, that constellation of findings is actually more associated with the closed spinal dysraphisms and can kind of push you over towards those. So moving into the closed spinal dysraphisms, as we can see, there are several subcategories within this. So we're going to start off talking about our closed spinal dysraphisms that have an associated sub-Q mass. All right, so we can kind of lump the first two of these together under the umbrella of lipoma with dural defects. And so that's going to be our Lipomyelomeningocele and our Lipomyelocele. Clinically, these are going to be a sub-Q fatty mass located above the intergluteal line and may extend down to the buttocks. There's going to be fat associated with the dorsal aspect of the placode, and it's going to be continuous with the sub-Q fat. Again, like many of these, they'll have cord tethering, associated symptoms of cord tethering. So to get to some images, here's a couple little diagrams to really emphasize the difference. Again, the naming of these can be helpful. That meningocele component is really the difference. And so in the Lipomyelomeningocele, you have kind of an external herniation of the CSF spaces, an expansion of the CSF spaces, and your lipoma placode interface is going to lie outside the spinal canal. In a Lipomyelocele, your lipoma placode interface is going to extend into the spinal canal. This can get a little confusing at times because even with a Lipomyelomeningocele, you can have kind of associated intradural extension of the lipoma. So the lipoma may kind of go within the canal itself as well, almost up like this, but the bulk of your interface will still be out here and you'll still have that herniation as we see in this patient. So here is an example of a patient with a lipoma with the dural defect. We can see very plainly on the X-ray this kind of fatty mass in the sub-Q soft tissues. If you squint, you can maybe see a little bit of soft tissue density even within those sub-Q soft tissues, within that sub-Q fat. But here we have kind of a correlating CT, and we can see some soft tissue density extending out here, and maybe even a little bit of fluid density there as well. Some other imaging this patient got, I think they got the gamut of everything here. So we also actually had a spinal ultrasound on them, which shows beautifully, and I've reoriented the plain film here to be at the same angle as the ultrasound. Here at the lumbosacral junction, we can see this herniation of the CSF spaces out here, and we can see this lipoma in the sub-Q soft tissues, and see that that lipoma placode interface there, kind of beautifully external to the kind of confines of the spinal canal. So then here for the same patient, which of course ended up being a Lipomyelomeningocele, kind of under that umbrella, we can see here on the MR, again, the herniation of the CSF here with that meningocele component. We can see the elongated tethered neural placode extending through that defect. Here on this sagittal cyst, you can kind of see it extending through a little bit better. And we see that the interface here is going to be external, though it's not included on these images. So we know it falls under that Lipomyelomeningocele bucket, despite the fact that, like I was saying, we do actually, on this one, you can see there is some herniation of some of that lipoma going into the canal. So here, to contrast that, is a patient with a Lipomyelocele. And here we see that there's no herniation of the CSF externally, and we have this intradural extension of the lipoma there. Here is another patient that has a Lipomyelocele that we can see with a much smaller defect here on the MR, and this intradural component of the lipoma. And you can see right here kind of that communication between the two, and this increased echogenicity here along those nerve roots of the Filum terminale there, along the nerve roots of the cauda equina, and kind of extending down by the Filum terminale there. We see that extra fat right here, this echogenic material within the spinal canal. There dorsally representing that lipoma. So now just to move on to a straight up meningocele, which has been such a component of our other verbiage here, but basically is just a straightforward herniation of a CSF-filled sac. It's going to be lined by dura and arachnoid, and the spinal cord is not really located within the sac, and that kind of separates it from these other entities that have that myelo component to them. But it can have spinal cord tethering associated with the neck of the meningocele, and it may contain nerve roots and or a hypertrophied filum terminale kind of extending into it or falling into it even. These are typically going to be lumbosacral when they are posterior in location, but anterior meningoceles are usually going to be in the presacral area, so located a little bit lower. The overlying skin with these will be intact. Doesn't have a kind of a fatty mass necessarily associated with it, but it'll have kind of an overlying layer of subcu fat and the dermis. So here is just a little schematic to kind of demonstrate that as well. And again, we have this subcu fat and epidermal layer kind of overlying it. So here's an example patient, another neonate here, and we can see that they actually have kind of a lower thoracic location of this meningocele. And here, I think particularly can see it nicely on the T2s. We have this kinking of the cord here posteriorly. We don't see any of the cord itself extending into the sac, but we do see that kind of kinking that makes us concerned for some tethering there. Next up, we have the Myelocystocele, which can sometimes appear a little bit similar to some of these. And basically, a myelocystocele is when you have herniation of a basically a syrinx, a dilated central canal through a posterior defect. So it has a meningocele component to it, but it also has a syrinx component to it as well. And they each communicate with their respective kind of origins. So the meningocele is going to communicate with our normal subarachnoid space. The syrinx is going to communicate with the normal central canal, and they're usually going to be separated off from one another. You can have these in both non-terminal or terminal locations. So here's kind of a couple diagrams. Here we see in this example, there's not much of a meningocele component in this location, just given the way that this is formed. And you can have kind of a variable extent to which you'll have either. With these terminal ones, you will inevitably likely have a little bit more of that subarachnoid space kind of surrounding it and have more of that meningocele kind of component that you see with it. So here is a patient, an example patient that had a terminal myelocystocele. And as we can see here on the CIS image, I think quite nicely, we've got this elongated neural placode that extends down into this defect, and we can see that it kind of splays open rather than kind of just sticking to one location and having the look of what we would think of as a meningocele, or if it were kind of focally tethered right here, even a Lipomyelomeningocele. It doesn't really have that look. It's got this kind of more open look, and we see that this CSF space is all communicating with our subarachnoid space, whereas here this is really kind of coming from the center of that neural placode, so coming kind of from that central canal. And you can kind of see here as well, when you look a little bit more ventrally, that there are some associated kind of sacral agenesis features here as well. All right, moving on to our next grouping, we're going to look at the closed spinal dysraphisms without subcu masses. And within those, we're going to split them into simple and complex dysraphic states. So under our simple dysraphic states, we kind of have a fairly heterogeneous group here with 5 different things that we can kind of see within that group. And they are going to be our most common type of dysraphism that we have in older children. If you just kind of quickly look at the list, you can see why these are going to be a bit less severe and present a bit later in life than the ones that we just covered. And obviously going to be a little bit less visually notable. So we will start off with the intradural lipoma, which is going to be a midline dorsal lipoma within an intact dural sac. And so that's going to be the difference between our Lipomyelocele, where we had that intradural lipoma extending through the defect. This one is actually going to have an intact dural sac. So it's going to look fairly similar, but we'll see kind of an image here in a second. They're usually lumbosacral in location, have, of course, associations with tethered cord syndrome, and the lipoma itself can cause cord displacements. And here we have an example of one. You can kind of nicely see how the posterior elements are preserved, but we have this lipoma here with this elongated neural placode extending down to it kind of near the lumbosacral junction. And here on our T2 fat sac can kind of see that cord a little bit nicer and see all that fat suppression associated with the lipoma. These can, like lipomas elsewhere in the body, kind of wax and wane in terms of, like lipomas elsewhere in the body can kind of wax and wane in terms of their size, kind of just corresponding with the actual weight gain of the patient with their kind of overall, body fat composition. So a little bit of change like that isn't anything necessarily too alarming, though obviously, could be associated with some of the worsening symptomatology. So filar lipomas or filar fibrolipomas are basically when we have fibrolipomatous thickening of the filum terminale. I think all of you have likely seen tons of these. It's essentially almost a normal variant. Somewhere between 1.5% and 5% of normal adults have those. And this is considered to be, kind of in that spectrum of the secondary neurulation abnormalities, but obviously can be very minor and can be somewhat variable in terms of its presentation. So if it is associated with other findings of tethered cord syndrome, then it can be kind of something of a little bit more concern. So here is an example of a patient with a filar lipoma and an associated kind of low-lying conus. The patient had symptoms of tethered cord as well. So the tip of the conus was extending down to L3-4. And here on our T1 images can see this nice bright lipoma extending down there with the filum. Here you can see that tip of the conus kind of extending down pretty low here on the sagittal cyst here. And another entity, tight filum terminale, kind of similar visually on the spectrum of these other diseases, especially with the fibrolipoma of the filum terminale. So we can have a lipoma, fibrolipoma, and then tight filum terminale is kind of shortened, hypertrophied, and thickened filum terminale, and so I think of it kind of more on that fibrous end of the fibrolipoma, whereas we see plenty that are almost full lipomas. And so this can have associated cord tethering with it and low-lying conus medullaris. It often is going to be seen in association with other malformations, and again is one of our secondary neurulation kind of abnormalities. So here's an example. In this patient, we see a low-lying conus, a little bit of a syrinx forming there in the distal cord. And then here on the axial T1, we can see that there is no lipomatous component associated with this. So it really kind of fits more that mold of a tight filum terminale rather than a fibrolipoma or a lipoma. Oh, another example. And moving on to the next one of these is going to be our dorsal dermal sinus. And that's basically an epithelial tract remaining between the CNS and the meninges extending to the skin. About half of these are going to terminate in an intraspinal dermoid or epidermoid, as we can kind of see here on this diagram with this little star. Going to be located at the conus medullaris, or at the kind of level of the cauda equina. And this is thought to really happen from kind of a focal incomplete separation of the neuroectoderm and the cutaneous ectoderm. So kind of really primarily during that kind of first stage of neurulation, the primary neurulation, when we have that infolding. Just kind of a little focal defect left there. And these are going to be much more common in the lumbosacral location, but can also happen in the occipital location as well. These typically are going to present with a midline dimple, a hairy patch, capillary hemangioma, hyperpigmentation, kind of some of our common findings of spina bifida occulta that we see on clinical exam. But the importance of these is that they can be a nidus for infection. So as soon as they're found, they require early surgical repair. And so this is why, you know, some of these things like midline dimple, et cetera, or a hemangioma in the sacral region can trigger some of our additional imaging, often first line with a spinal ultrasound, but then frequently work their way down to us in neuroradiology with further imaging. So here we have a newborn patient with a little dimple, as we can see here, and we can see the associated low-lying kind of blunted appearance of the cord, and we have this little track extending through here in keeping with a dorsal dermal sinus. Terminal ventricle is going to be our next one in this group. I think our last one in the group before we move on. And that is just basically a hence the name, it's an ependym-aligned cavity, and it's located at the level of the conus. I imagine that most of you have seen or heard about these before. And, you know, we can kind of bring forward this idea and differentiate it from a regular syrinx or hydromyelia because of that location just above the filum terminale and the conus. It's a non-enhancing lesion, and oftentimes will be asymptomatic, but can actually present in adulthood with some bladder or bowel sphincter dysfunction. And this is basically during that secondary neurulation step, there's kind of incomplete regression of that central cavity that forms, if you remember back to those earlier images. So here's an example of a child with a kind of dilated central canal here, just at the level of the conus here on the sagittal and axial T2s. This was actually an asymptomatic child. But here's one kind of taken from the literature, or actually taken from Radiopedia, of an older patient with a cystic dilation here of the terminal ventricle, very focally, and we can see that this is within the confines of the cord itself. And this patient actually had a neurogenic bladder associated with this. So you can see how some of these can be more severe. Here is a fetal MRI that we had locally that has one that almost looks like that adult. As we can see here within that distal cord, we see this nice kind of ovoid dilation here on our coronal images, two successive coronal images here, and then two successive sagittal images showing us just that focal dilation there in the level of the conus. So kind of suspected that to be a dilated terminal ventricle. I know I said that was likely our last entity in this group, and this is actually kind of showing you guys a little bit of a pitfall, a red herring. to be aware of. Hopefully people are familiar with this entity, and in the world of neuroradiology, we often aren't the ones reading the spine ultrasounds, so often these will kind of come to us as a downstream finding, but a filar cyst is what we see here on the ultrasound, kind of demarcated by the calipers. We see this little focal cystic lesion right there at the level of the cauda equina. So you can tell that we are below the conus medullaris. And even though this may not be something that you'll necessarily read in the neuroradiology world, I think we've all likely seen this miscalled, called a terminal ventricle or something along those lines. And so understanding it and being aware of it is an important thing for us. And here on this same patient, we have a follow-up MR, and we can actually see on the CIS image a correlate to it. So a filar cyst, really just an important pitfall to be aware of, that it's a normal variant incidental finding in spine ultrasound. Thought to maybe be an artifactual finding. And here, I have a article cited from 2006 where, they kind of say how it's not typically seen on MRI, though we have our example just on that prior slide where you can see it on the MRI. And so I think some of that is likely, just kind of progression of our imaging techniques with time that are making them a little bit more visible. But they did, at least in that case series, have, I think, one patient that was autopsied and no correlate was found. And, these are typically a finding that we see, if at all, in infancy, whereas we don't really see them in older ages. And so it seems like if it is an actual thing, it's something that's kind of regressing on its own. All right, now moving past the simple closed spinal dysraphisms, let's move on to the complex closed spinal dysraphisms without a sub-Q mass. Within this, we can kind of split it into two different groups, the ones that are formed from a disorder of the midline notochordal integration, and the ones that are disorders of notochord formation. So we're going to cover that first half with these two, the Neurenteric Cyst and the Diastematomyelia, and then we'll go on to the other two. So starting with the Neurenteric Cysts, these basically represent an incomplete regression of the neurenteric canal. It's going to be lined with mucin-secreting epithelium similar to the gastrointestinal canal or gastrointestinal tract. And remember, we have this kind of close association with the mesoderm and the neuroectoderm when all of this is happening, and the mesoderm goes on to form several of these visceral organs. And so it's kind of all interrelated there in the embryology of it. And then kind of along the same spectrum of a neurenteric cyst is a dorsal enteric fistula, which is an extremely rare entity, but it's going to be a connection between the skin surface and the bowel. So our neurenteric cysts are going to be in an extramedullary intradural location. These actually typically are going to be cervicothoracic, unlike many of the other anomalies that we've been talking about. And, given kind of where they develop from developmentally, they're actually going to be in more of an anterior location rather than dorsal, like several of the others that we've talked about. Unsurprisingly, again, given how all of these structures are interrelated there with the development, the vertebrae associated with them will often have an associated anomalies, kind of particularly the ones closest to the neurenteric cyst, and particularly ventral anomalies, given again just the position of these. On imaging, they can be iso-intense to CSF, or they can be a little bit hyper-intense, particularly on the T1s, given the high protein content. And typically, we do not expect enhancement with these. So here's an example patient. We can see on this sagittal CT post-contrast image, this almost a CSF density mass effect here upon the ventral cervical cord. But then correlating that with the MR here on our T1, we can see what looks a little bit hyperdense to the CSF, just a tiny bit, but then also there's this little bit of kind of increased density layering here along the inferior aspect. Here on the T2, we see that it's really got a nice bright signal associated with it, and on our post-contrast image, maybe a little bit of rim enhancement here posteriorly, but not a really substantial enhancement to it. To show you kind of the more severe end of the spectrum, here's a neurenteric cyst extending through the defect in the vertebra just ventral to it, with a component extending kind of into the posterior mediastinum. And here we have some enhancement about it here on the post-contrast images due to just some of the inflammation going on at the time of this imaging. And on the 3D reconstructions of the bone here, we can see that vertebral defect through which it is extending really nicely. Next up, we have our split cord malformations. So Diastematomyelia is going to be kind of our typical one, but Diplomyelia also kind of falls into this general bucket. And Diastematomyelia is going to be the separation of the spinal cord into two hemichords, whereas Diplomyelia is thought to basically be two duplicated full cords extending through the spinal canal. This is going to be our most common defect of midline notochordal integration, actually. Like the others, can be commonly associated with vertebral anomalies and hydromyelia. Clinically, like many of these others, the patients can have scoliosis, tethered cord syndrome, and can have hairy tufts. But in this instance, the hairy tufts often correspond to the location of the diastematomyelia, so can be a bit higher than we would expect in some of these other dysraphisms where we see them kind of lower in the spine. There's two types of diastematomyelia, and they're about half and half in terms of their prevalence. Type 1 is where we have separate dural tubes and we have a bony or cartilaginous septum. And type 2 is a single dural tube with a fibrous septum. So here's just a diagram kind of showing that. And here is an example patient. Just go ahead and show the text here at the top, but we can see this patient has some cord tethering, had a Lipomyelomeningocele, I believe, that was repaired, and has some syrinx within their distal cord. And I apologize, I called this tethering, but it's a low-lying placo because they are post-operative at this point, and so we don't want to necessarily use the word tethering. Here we can see in their lower thoracic spine, they have a butterfly vertebra there. And at that same, or actually I think a little bit below that level, here we can see the split cord very nicely with no cartilaginous or bony or any sort of septum between them. So that tells us this is a type 2. In contrast with this patient who has a type 1, and here we can see a couple different levels on the axial T2 here where it is kind of where the two hemichords are kind of joining together, but here where they are fully separated, and we can see this nice bony bar with that signal dropout in the correlate here on the CT. All right, so lastly, moving on to our defects of notochordal formation. That's going to be caudal agenesis and segmental spinal dysgenesis. Caudal agenesis is going to be partial or total agenesis of the spinal canal at its kind of most caudal distal components. Has common vectoral associations that we are all well aware of, and can really have two different types. It can either be in a high position of the conus with an abrupt termination, or it can have kind of a low position and the tethering that we're more used to seeing. So here's an example, and we can see this nice blunted cord, these incomplete sacral and coccygeal elements, and the syrinx here within the distal cord. Here on our X-ray, we can also really beautifully see just kind of the lack of of a formed sacrum here as well. Moving on to our last entity, segmental spinal dysgenesis. This is a very rare defect of notochordal formation, and it actually is going to be involving an intermediate segment, hence the name. And so basically this segment of the spine and the cord fails to develop properly. And so it's often going to be in the lumbar or thoracolumbar region. You have abnormal cord and roots typically at that level. And these patients can have congenital lower limb deformities and paraplegias, paresis of their lower limbs as well. The vertebrae, interestingly, above and below the anomaly are both present and can look relatively normal. There can even be a lower cord segment within the caudal spinal canal below the anomaly that itself may look relatively normal. So here is an example patient that we had, and you can see just this elongated neural placoid. Unfortunately, with the edema and syrinx all through it, it actually becomes kind of hard to see on the T2, but here you can maybe see the cord a little bit better on the T1. We get to this level, which looks like it was about L3 here per our annotation, and we've got some hypoplastic, dysplastic, and I believe even maybe lack of one or two of the vertebral elements there with an associated kind of dislocation, subluxation there. And we can see the neural elements kind of extending down below that as well. Here's our CT correlate, just helping us see the vertebrae better. And actually what the patient initially presented with was this MR imaging, or sorry, the ultrasound here prior to the MR imaging, where we can see this thick cord extending down. We don't really have a conus, and so we see it extending down to this defect where we have a step off from these abnormal vertebrae. And we can rotate that a little bit to kind of put it at this same angle and make it a little bit easier to look at compared to our MR and our CT. So last but not least, going to touch on post-operative image here very quickly. We only have a couple minutes left. Again, I apologize for all of my technical difficulties. With essentially all of these dysraphic defects, surgery is going to be our treatment of choice, typically comprised of closure of the defect and detethering of the cord. These patients are going to require lifelong supportive care and follow-up. We will be doing lots of imaging of them in the post-operative period, and any worsening of their symptoms will trigger another MRI. Things that we are going to be looking for with our imaging, of course, like any sort of post-operative imaging, you want to look for wound infections, wound dehiscences, infection of their shunt catheters. As we discussed early on, many of these patients can have hydrocephalus, particularly with our open spinal dysraphisms. Shunt infections can be a common complication in them as well. And since they have to undergo spinal surgery, CSF leaks are another thing of concern. Adhesions with retethering due to all of the post-surgical fibrosis can be a problem in these patients, but keep in mind that the spinal cord is not going to spring back into a normal position after the detethering procedure. So a low-lying cord, or you heard me accidentally call that one patient that was post-op tethered that had I forget even which entity that was. But had a couple of concomitant entities there, and I slipped up and called it tethered because you don't want to really pin that patient in a box like that because the cord's not going to bounce back, and the tethering is really a bit more of a clinical diagnosis. You can look for secondary things like edema forming kind of within the cord, like a pre-syrinx edema, or formation of an actual syrinx, and those types of progression of findings can be things to kind of point you towards a retethering, but again, a lot of it's going to be clinical. Another thing to consider is prone positioning MRI, which can even be done sometimes in the preoperative kind of troubleshooting of patients when you're trying to figure out if the cord is tethered. And then, of course, dermoid formation, now that we have introduced external elements into the spinal canal, is a concern in these patients in the postoperative period. So that pretty much wraps it up. Again, sorry for the technical difficulties that we had. And here's, again, just kind of this big overview of the different categories, the different breakdown of where all of these fall, and how we can kind of think of them a little bit separately and separate them out.
Awesome. Thank you so much, Neil. That was a wonderful overview of all of these great entities, which can sometimes be very confusing. So thank you so much. If anybody has any last minute questions, feel free to put it in the chat, or you can contact me or Neil directly. Join us next time. Dr. Kobos will be talking about MRI of normal fetal brain development. That'll be January 19th. I'll send out a reminder to everybody as well. And then also, if we advance, Neil, everybody, a shout out to ASPNR, which is January 13th and through 15th in New Orleans. So hope to see everybody there. Be another great avenue for education. So thank you everybody for coming, and look forward to seeing you next time.